will focus on the importance of establishing and maintaining antimicrobial stewardship programs, specifically as it relates to improved patient outcomes. I'm Pam Andrus, and I'll serve as the moderator for this discussion. The webinar is scheduled to last approximately 30 minutes with the Q&A immediately following. All participants will be on mute, so if you have questions, please type them in and we'll answer them at the conclusion of the presentation. For more information on CompleterX, along with upcoming webinars and events, please visit the CompleterX.com website. I'd like to get started by introducing our speaker, Dr. Kimberly Couch. Dr. Couch is a clinical pharmacist at Nanticoke Memorial Hospital in Seaford, Delaware, where she sits on the Infection Prevention Committee. She also serves as president of Infectious Diseases Pharmacy Associates, Incorporated. Dr. Couch has written or co-authored numerous articles on the subject of infectious disease, including the ASHP Therapeutic Position Statement on Strategies for Identifying and Preventing Pneumococcal Resistance, published in the American Journal of Health System Pharmacists in March of this year. I will now turn it over to Dr. Kimberly Couch.
Thank you. Good afternoon, everyone. And I wanted to get started with talking about antimicrobial resistance. And as you may know, antimicrobial resistance is now recognized as one of our most serious health threats. If we lose the antimicrobials that we currently have, that's really only going to undermine our ability to effectively treat infections in our most vulnerable patients. All of our efforts to prevent antimicrobial resistance should be coupled with our foundation of public health strategies, which includes immunization, infection control, antibiotic stewardship, and reducing transmission of infectious diseases. Our goals are to provide effective antimicrobial agents in sufficient doses, in sufficient duration to eradicate, prevent, or attenuate infectious processes. We can do that and improve the morbidity and mortality of our patients. Antimicrobial stewardship should also prevent or arrest the development of antimicrobial resistance. And finally, can reduce our overall costs of care for patients. Pharmacists really are our drug experts when it comes to dosing and administration, and therefore should be an essential part of an antimicrobial stewardship team. So let's start with a poll. And how many of you have implemented an antimicrobial stewardship program? So take a few minutes and think about this. And let's go ahead and close that poll. And so about half of people say that they do have an antimicrobial stewardship program. Some of you are on, and some in at this time. We'll talk a little bit about why we really need an antimicrobial stewardship team. And antimicrobial stewardship is really essential because we have an increasing incidence of resistant pathogens, which limits the number of antimicrobials we have to treat patients. That usually results in increased healthcare costs as well as increased patient mortality and morbidity and length of stay. This also results in kind of a cyclic fashion where we have an even higher incidence of resistant pathogens. And so unfortunately, all of these work in concert together to kind of increase all of these costs and mortality, length of stay, limiting our current antibiotics. And so we really need to kind of break that chain. And an antimicrobial stewardship team can really help us in breaking that chain. So when we think about it, we know that in 2013, antimicrobial resistant organisms resulted in over 2 million illnesses for patients and over 20,000 deaths for patients. Clostridium difficile is a particularly problematic pathogen, not because it's so resistant, but because it's directly related to antimicrobial use. And this resulted in 250,000 illnesses and over 14,000 deaths in the United States alone in 2013. There are 4 core actions that are essential to preventing antimicrobial resistance, and we can do that by preventing infections and preventing the spread of resistance, tracking the incidence of resistant organisms, improving our antimicrobial stewardship and prescribing, and we know that that is probably the most single important action that we need to implement to really slow down development and spread of antibiotic-resistant infections. And then lastly, developing new drugs and new diagnostic tests so that we can identify pathogens earlier and more accurately. Preventing the spread of antimicrobial resistance really only will be achieved as we work together as a collaborative group with the engagement of many different healthcare providers, including pharmacists, physicians, nurses, respiratory therapists, including healthcare leadership, as well as infection preventionists. One of the ways that we can reduce antimicrobial resistant infections and infections in general is to appropriately vaccinate patients. And along with Teresa Guidi, we published an article in the American Journal of Health System Pharmacists in 2014 addressing the new recommendations for pneumococcal vaccination, as there are 2 pneumococcal vaccines now that should be used, and there are specific times in which each of those should be used. Our screening for patients for pneumococcal vaccination has gotten a little more complicated. And as you can see with the flow diagram in front of you, we have several choices that we need to make, whether we are going to give the Pneumovax 23 or the Prevnar 13 to patients when they're in the hospital, and when they should have follow-up for subsequent immunization. In addition to that, we know that the CDC has developed a prioritization of pathogens that are concerning and has established a new ranking system for threat levels for particular bacteria and fungi. Now, the urgent hazards to patient health and health care include Clostridium difficile, our carbapenem-resistant Enterobacteriaceae, and our drug-resistant Neisseria gonorrhea. Most of the time, we'll encounter C. diff or Clostridium difficile and carbapenem-resistant Enterobacteriaceae, or CREs, in the hospital. Drug-resistant Neisseria gonorrhea typically is limited to a clinic-type setting or the emergency department-type setting. The CDC has worked out a system of ranking pathogens, and it depends on how many antibiotics we have to treat those particular pathogens, what the incidence is of the pathogen, and what the consequences are of an infection with that pathogen, whether they've categorized those pathogens as urgent, serious, or concerning. The pathogens that we would encounter most frequently in the hospital or health systems for serious hazards include our multi-drug-resistant Acinetobacters, our extended-spectrum beta-lactamase-producing Enterobacteriaceae, or ESBLs, multi-drug-resistant Pseudomonas aeruginosa, methicillin-resistant Staph aureus, our drug-resistant Streptococcus pneumoniae, which we can prevent with vaccination appropriately. And then the concerning pathogens include vancomycin-resistant Staph aureus, our clindamycin-resistant Group B streptococci, and erythromycin-resistant Group A streptococci. Clostridium difficile is one of our urgent hazards, and the reason why it is an urgent hazard is because this particular pathogen spreads rapidly. Half of all of the infections occur in a hospitalized or recently hospitalized patient as a result of antimicrobial exposure. There are few agents available for treatment, and the incidence of Clostridium difficile has increased 400% over the last 5 years, especially in patients who are above the age of 65 years. Clostridium difficile also results in at least a $1 billion excess healthcare costs annually within the United States alone. Our extended spectrum beta-lactamase producing Enterobacteriaceae, mostly our E. coli and Klebsiella species, is a serious concern, and these ESBL producing E. coli and Klebsiellas, because they have this extended spectrum beta-lactamase, they are frequently resistant to most beta-lactams. There may be some of the agents in the beta-lactam group, like the carbapenems, that remain sensitive for these, but many of those agents are fully resistant. In addition to that, the ESBL-producing Enterobacteriaceae are very frequently resistant to other antibacterials like the fluoroquinolones, the aminoglycosides, and so this really limits our number of agents that we have available to treat these particular bacteria. We also know that there's a 57% increase in mortality for patients who end up with an ESBL-producing bloodstream infection with either E. coli or Klebsiella. So we know that mortality is substantially increased. We have few antibiotics to treat this, and unfortunately, usually it confers resistance to other antibacterials. Methicillin-resistant Staph aureus is a leading cause of hospital-acquired infections, accounts for over 80,000 invasive infections annually, and a little more than 11,000 deaths annually. Methicillin-resistant Staph aureus, or MRSA, is very commonly resistant to other classes of antibacterial agents, such as our aminoglycosides, our fluoroquinolones, clindamycin, and so leaves us with very few agents to treat these particular types of infections in patients. Clindamycin-resistant group B streptococci are concerning illnesses, and we know that group B strep causes severe illness in all ages of patients, but we also know that group B strep is a leading cause of serious bacterial infections in newborns and can lead to bloodstream infections, meningitis, and pneumonia. When we have an isolate that is clindamycin resistant, it's also commonly resistant to erythromycin, and so it really limits our choices for prevention and treatment of infections for patients that are allergic to the penicillins. So we know that the patients who develop infection with these clindamycin-resistant group B streptococci who are also allergic to penicillins have very few choices. In addition to this, sometimes we use clindamycin as a prophylactic agent in our pregnant women when they're in delivery if they're colonized with group B streptococci. And so we really have a limitation there as well if the mom is allergic to penicillins, and can result in transmission to the infant. So all of these agents are particularly concerning. However, we also know that there are some new rules that were implemented as of August 1st of this year with the inpatient prospective payment system. And with the patient safety indicators, we know that central venous catheter-related bloodstream infections and postoperative sepsis will be included in the measurements. In addition to that, healthcare-associated infections, particularly CLABSIs and CAUTIs, or catheter-related bloodstream infections, or central line-associated bloodstream infections, and catheter-associated urinary tract infections will be on the list for healthcare-associated infections. And in fiscal year 2016, surgical site infections will also be within the group of healthcare-associated infections that are monitored and included in our benchmarking for inpatient prospective payment systems. Additionally, readmissions related to pneumonia and COPD will continue to be included, and other readmissions will as well, but these are particularly antibiotic or antimicrobial stewardship related. For value-based purchasing for fiscal year of 2017, we'll have 2 additional outcome measures in the safety domain. And those 2 additional measures include hospital-onset methicillin-resistant Staph aureus bacteremias, as well as Clostridium difficile infection. So we will be looking at those data, and those data will be reported for each individual hospital, and then the value-based purchasing from CMS will be including those measures. For the IQR measures, the sepsis bundle will be included in the measurements. Hospital-wide all-cause unplanned readmissions will be included, and that includes any type of readmission. So it may be that your patient was in the hospital for a pneumonia, they were given antimicrobial agents for a period of time, discharged with either a prescription to complete an antibiotic course, or were discharged after completing their antibiotics. And then if they're readmitted to the hospital, perhaps for a C. difficile infection, then you get kind of 2 categories checked off because you have a C. difficile infection, and then you also have an unplanned readmission for that patient. So anything that we can do within an antimicrobial stewardship team or within our hospital to help reduce these really will help those IQR measures and safety domain measures. Lastly, what will be also incorporated is influenza vaccination of healthcare workers. Now, of course, they're still going to be looking at our vaccination of patients, but now they will start incorporating the influenza vaccination of healthcare workers. So how well everybody is doing with vaccinating their people who work for the hospital, as well as any licensed individual practitioner as well. So antimicrobial stewardship really is essential in decreasing antibiotic resistance, decreasing the C. difficile infections, as well as decreasing costs associated with those. It certainly does increase good patient outcomes through reducing consequences of antibacterial agents, improving our antibiotic resistance, and preventing infections for patients. So I'd like to take this time and take some questions from you.
Okay, thank you, Kim. Before we start our Q&A, we want to thank you all for your participation today. The presentation will be emailed out to all attendees, and the webinar with audio will be uploaded to the Knowledge Series section of the CompleteRx website, where you can download it at your convenience. If there are specific questions you'd like Kimberly to address one-on-one, you're welcome to email her directly at the email address listed on the screen. So the first question we have is, who all should be involved with the antimicrobial stewardship team within the hospital?
That's actually a good question, especially for folks who are thinking about implementing an antimicrobial stewardship team. Essential people for an antimicrobial stewardship team include a pharmacist who has knowledge or training in antimicrobial stewardship, infectious diseases, infection prevention, or another similar type of discipline. In addition to that, a physician with a particular interest in infectious diseases should be included. For some hospitals, they may not have a specific infection that has a particular interest or background in infectious diseases. Other people that really need to be included are the infection prevention, nursing, representatives from information technology, so that there can be coordination of the different elements that are needed from your computerized systems, as well as someone from the laboratory group, preferably someone from microbiology. Also, an administrator is really essential to an antimicrobial stewardship team. And really, leadership support will be what gets the antimicrobial stewardship actions implemented and carried out throughout the hospital system to help reduce those costs associated with antimicrobial resistance and antibiotic use, as well as improving care for patients overall.
Okay, our next question is, for an institution that doesn't have an antimicrobial team, what are the most important tasks for getting started?
So really the most important tasks for getting an antimicrobial stewardship team started include things like, first off, identifying the appropriate people to gather together and really decide, where are kind of the first places that they want to start with. And there are some very simple items that can be started, and as you achieve success with those simple tasks, branching out to more complex and really getting others involved in antimicrobial stewardship is essential. So simple tasks like implementing an intravenous to oral conversion program for not just antibiotics, but for other agents, so that you can reduce the number of IV sites for a patient, which may lead to phlebitis and infectious complications. Also, narrowing the spectrum of antibacterials, so patients are on appropriate antibiotics, but not excessive antibiotics, and limiting the duration to what's appropriate for a particular course of therapy.
Okay, our next question is, do you use software to enhance stewardship process?
I think that using software to enhance stewardship process is something that is very helpful for many institutions, especially very large institutions. For smaller institutions, it may be something as simple as having the microbiology lab print out or email copies of all of the positive cultures for the past 24 hours and having someone review that. So it depends kind of on the volume of information that there is available. There are many different software packages that are available that can help you, that will pull in data from the laboratory, data from the pharmacy part, and can help integrate those to, kind of help fine-tune a list of actions to take for the day. However, if you have a small enough institution, it's not necessary, or it may not be required to implement one of those software systems when you can get the data readily and work with it if it's a manageable load of data.
Okay, our next question is, how long does it take usually to see results regarding resistance rates after implementation?
Okay, so how long does it take to see results for resistance rates after implementation? It really depends on what organisms you're looking for and kind of the incidence of those organisms within your institution. So, for example, at an institution, they were seeing problems with increasing reduced susceptibility of their MRSA isolates to vancomycin. And so they did implementation of other drug choices, and when they made that implementation, within 1 year, they really turned around their increasing incidence of more resistant isolates to, they cut back from 49% to less than 17% within 1 year. So it can be quick if you have, a certain population. For isolates that are less frequently encountered, it's going to take more time to see those differences. And I want to say also, you may not see such stark differences or reduction in antimicrobial resistance. You may actually just see a leveling off of resistance rates. So while, maybe you had a stark increase in resistant isolates, if you see a sudden leveling off, that shouldn't be perceived necessarily as no change, because it's really, you've gone from a sharp increase to no change over a short period of time. And so that's really a win for a stewardship program.
Okay, thank you. We've got a lot of really good questions here, so we'll move on to the next one. What options exist when a patient has a pan-resistant organism?
So what options exist when a patient has a pan-resistant organism? So by definition, a pan-resistant organism would be an organism that's resistant to everything that was tested. Usually what we do in those cases are we kind of take out some of our less frequently used antimicrobials that may be older agents, perhaps have, are used less frequently because perhaps they have a higher incidence of toxicities or side effects associated with them. Depending on, which organism it is, we may have some agents that are available to treat those particular pathogens. The alternative is that we can have those isolates sent out to a specialty lab for very specialty testing, and we can look for combinations of agents which may be somewhat susceptible for that particular organism. So maybe one agent by itself is resistant, but when you combine it with one or two other agents, it may actually give you an effective treatment for that particular organism. That does require specialty testing, which typically needs to be done in a laboratory setting in a research facility. Lastly, one of our options is that we can look for an investigational agent which might be useful in treating those patients. So certainly those are all options that we explore when we have a patient that has an isolate that's resistant to everything that we've looked at so far to treat that patient.
Okay, what challenges can you expect from physicians, and how do you overcome them?
So the challenges that we can typically expect are, there certainly are, there's resistance to an antimicrobial stewardship team. People like to feel that they are making good choices for their patients. And, everybody gets into healthcare to really help patients feel better and make patients better. So we like to feel that we're doing the right thing for patients. And, in that case, when we have people, we really try and engage more in a collaborative type of discussion about how a patient's being treated with their antibacterials. Maybe we could de-escalate a little bit. Maybe we could shorten the duration if there are no positive cultures, things like that. So more engaging in a collaborative type relationship and trying to leave the other types of things at the door so that we can really help the patient to get better. In addition to that, sometimes there are challenges with funding an antimicrobial stewardship team. However, I think that with an administrator included in the antimicrobial stewardship team, and they don't have to necessarily come to every monthly meeting or every bi-weekly meeting, however often you're going to have meetings in the beginning, but they really need to be there to support the team and see some of the benefits and successes for the antimicrobial stewardship team and see how it benefits the hospital as a whole. We need to think about not just this particular patient's infection at this time, but we also need to think about preventing that patient from coming back into the hospital because of a complication of their antibiotics like C. difficile. We need to think about preventing them from coming back for an illness because perhaps we didn't vaccinate them appropriately. So we also have to think about healthcare prevention within a hospital or health system to really help us achieve some of those goals and make sure that we are doing well with our value-based purchasing and the prospective payment systems as well.
Okay, and this will be our final question. For an OB patient, should antibiotic regimen be stopped post-delivery or continue to eradicate the infection in the mother?
So for an obstetrics patient, typically the antibiotics that we start for them are because they have they're colonized with group B streptococci, and it's not useful to continue those antibiotics after delivery because we won't really eradicate that colonization. Now, certainly if the mom has another type of infection or an active infection at the time, we would need to give her some antibiotics for that or antivirals for that, depending on what type of infection she has. For surgical site prophylaxis for moms who are having C-sections, you really don't need to continue their antibiotics post-operatively. It's considered a gray area. It's not necessary, but it's not wholly discouraged either. But we do know that there are certainly obstetric patients who have developed C. difficile after their antimicrobials for C-section, surgical site prophylaxis. And so anything that we can do to kind of reduce those is something that should be one of our goals.
Okay, thank you, Dr. Couch. This concludes our Antimicrobial Stewardship webinar. We want to thank Dr. Kimberly Couch and all of our attendees for your participation. Have a great afternoon.